So today, and this is something that's really been changing over the years, we have many different classes of therapy available for EGFR mutant disease. We have the original EGFR targeted therapies, and that's right now osimertinib, which I mentioned before is a third generation EGFR inhibitor pill. But there are other classes of therapy we use either upfront or along the way for our patients with this diagnosis. And that may include chemotherapy, and usually does include chemotherapy at some point. Classically, the combination is this carboplatin plus pemetrexed, which you may have heard those names before. We also have EGFR-MET bispecific antibodies. That's amivantamab now available, which is active for this particular diagnosis. And maybe in the future, as you heard in our last talk as well, antibody drug conjugates have shown some activity. They're not currently approved for EGFR lung cancer, so we don't have anything we can write just now about a clinical trial, but it's certainly an area that I think is interesting as an example of emerging therapeutic classes. So how do we use these? And I usually tell patients that I expect we're going to use all of these in some format at some point. And in some ways, the question is, how do we combine them and sequence them to gain the greatest effect against the cancer, while ideally retaining the best quality of life possible, trying to minimize the amount of time people spend with toxicities of therapy. And of course, that may be different from one person to the other, depending on health or preferences around care. So where are we, now with treating newly diagnosed lung cancer with a classical EGFR mutation as of 2024? We really have three big options that are all available, that all have good data. I'm actually going to run through all three of these to kind of get into some of the nitty-gritty of what do we know about these different treatment options. Option one is osimertinib monotherapy. That's a pill-based regimen. It's one pill a day. So it has the advantage of being an oral regimen. So no IV infusions required, and generally fewer side effects than the combination-based regimens I'll talk about. Fewer therapies, fewer side effects of therapies. But as we look at the data, it does have now a shorter average duration of benefit compared to going with a more intensive upfront combination. What are our upfront combinations? Option two, I would describe as being osimertinib combined with chemotherapy. And that's that combination of carboplatin pemetrexed chemotherapy I mentioned about 2 slides back, I think. And this has the advantage, it's more intensive upfront therapy. You're adding chemo right from the beginning, right at newly diagnosed. And this does come with a longer average duration of benefit before having to switch to, say, your next type of treatment. But it does come with more side effects, especially early on with the chemo regimens a little stronger, a little more intensive. And it does add IV infusions every 3 weeks or so. So, you're taking on sort of the chemotherapy infusion experience and the quality of life impacts by doing this. Option three is actually our most recently approved option. And this is that combination of amivantamab, which is that EGFR-MET bispecific antibody, combined with another EGFR pill, lazertinib instead of osimertinib. And this similarly has shown a longer on average benefit compared to osimertinib alone, but it does add IV infusions as well every 2 weeks. And it probably has, I think, the most side effects kind of in an ongoing fashion during therapy. And that sort of limited some of our excitement about using this upfront in the first line setting. We will run through the data.